I think that the most important group that I need to thank are the patients and the relatives. I always say this, and I would repeat the same. We learn a little bit from the doctors, probably a lot from the social care network provided by the parliamentarians and also by the neighbors. But if you want to learn medicine, you have to learn it from the patients. And that is what I learned. When I did my PhD in hypothalamic pituitary axis, I found that the patients and their relatives were very close to me, because those are the people who actually gave us challenges, and those are the people who gave us courage to handle the challenges. So I'm very grateful and very honored to be in front of the patient and the patient group. Thank you very much. What I would like to do is to touch a very important subject of bone problem. Indeed, the lecture is full of scientific data and so on, and I would just deliberately cut it because I don't want to extend this topic and take your whole evening. So let's start by talking about the bone problem. As you know, that thalassemia, although I'm mainly talking about thalassemia, I'll talk about sickle cell disease at the end. Now, the first point I want to say is that you probably know about Cooley's triad. In 1920s, Cooley discovered what is known as thalassemia, and Cooley's disease is a condition where there is peculiar bone changes, and peculiar bone changes in those days, in 1920s, were not very well known. Along with it, there was hemolytic anemia as well as splenomegaly. The point I want to make is that the patients had a peculiar phasis, and that is of course changed. And the thalassemia patients, as you will understand, were born with a bone disease. So it's very, very important for you to understand that these patients were born with bone disease, and this bone disease has been modified because of the treatment with blood transfusion and also chelation. So the natural history is altered. And this main bone problem was because of ineffective erythropoiesis with resultant marrow expansion, and therefore these patients had fracture risk. And as I pointed out, that there is the altered natural history because of transfusion and chelation. And we are still learning to understand the bone problem. So if you look at this particular slide, you would see that there is cortical expansion. The intramedullary expansion causes thinning of the cortex, and that is what causes the fragility fractures. Now, it affects 80 to 90% patients, so 60 to 70% is even an understatement. And it's not a bony disease, it is a disease of the cartilage, disc, and spine. It is associated with severe morbidity, many hospital admissions and fractures. The pathophysiology or the real problem is still unclear. And as I pointed out, that it is certainly because of intramedullary hematopoiesis, iron overload, anemia, and chelation, but many endocrine factors are responsible, such as the pituitary damage, which causes hypogonadotrophic hypogonadism, which I was covering. Again, if patients fail to go through puberty and do not attain optimal growth, please remember that the peak bone mass is suboptimal. And therefore, these patients it's just like having money in the Swiss bank. If you don't have any money, then you are more likely to become depleted. And that is what happens in these patients. Because the peak bone mass is suboptimal, therefore these patients are more likely to have fractures. So it's very, very important for you to understand that there is damage to 3 types of endocrine axis. One is the pituitary gland causing hypogonadotrophic hypogonadism. The second one is growth hormone IGF axis, and then vitamin D axis. I don't want to go into the rank L system, which is a system responsible for increased activity of the bone decaying cell called osteoclast. So what do we really know and what causes it? We know actually very little. We are learning. And if you want to know about the osteoporotic world, we are still toddlers. However, toddlers have learned how to walk. And I would certainly say that is how we can take strides. This is very important for you to understand that we do know what is osteoporosis, because this is based on the WHO or World Health Organization classification. Now, please understand that this is full of flaws as well, because this is based on postmenopausal women who only go through menopause and therefore they have hypogonadism or lack of sex steroids. But thalassemia patients not only have hypogonadism, which is not due to damage to the ovary or testis, but because of damage to the pituitary gland, but in addition they have qualitatively abnormal bones and abnormal geometry. So this osteoporotic classification, which is mainly based on postmenopausal osteoporosis, is an underestimate. Just to rehash and point out that these are the jargons, but osteopenia is a condition which is the precursor of osteoporosis, where the bone mineral density is between minus 1.5 to minus 2.5 standard deviation below the young normal mean. And if it exceeds the minus 2.5, then that is known as osteoporosis. But like I said, in thalassemia patients, osteopenic patients should be treated like osteoporotics. So this is just a picture to show you what the DEXA scan is like. Many of you, and especially if you have thalassemia or sickle cell disease, I'm sure you would have had it in one stage or the other in your life. We recommend that all patients should have it annually. Now what you can see is that this is the bone mineral density score on the left hand side, and then on the horizontal axis we have got the age. And these stars, what you can see, are indicative of severe osteoporosis. This is the average, and the top and the bottom are the maximum, to put it in a crude way. So this patient is only 20 years old, and you can see the patient has got thin bones. Almost invariably, the patient had delayed puberty or incomplete puberty, or the intervention was done very late. So I mentioned to you that thalassemia, or the bone disease in thalassemia, is not just osteoporosis. It may be due to various genetic factors, and we tried and tested with various candidate genes with the assumption that if it was hypogonadism, purely just like the postmenopausal women, then HRT would correct it. And I won't go into the great details of science, but just to explain to you that postmenopausal women who have osteoporosis respond to sex steroids. And when I say sex steroids, I'm mainly talking about estrogen replacement therapy. There is cross-sectional data as well as retrospective data, and our data to suggest that hypogonadotrophic hypogonadism, which is the damage to the pituitary gland, is the commonest problem. And in this study group, what we did is we picked up males and females with this kind of problem, and we treated with sex steroids, and we compared with a pure model, that is premature ovarian failure, who only have sex steroid insufficiency, and found out whether it helps just with sex steroid replacement therapy to correct the deficiency. Now in this table you can see women who are cycling versus those who are not cycling, implying that they have got absence of periods. The patients who had absence of periods or who were acycling were more iron overloaded with ferritin and more organ dysfunction. Same thing was found in males. Now, if you now look at what happens following replacement therapy, please notice that these patients responded extremely favorably with HRT. So what have we learned so far? HRT is the first line of treatment. If there is absence of sex steroids, one must treat it judiciously. The same thing you can see in hip, but there is less response in hip than spine. Now this is the premature ovarian failure model, and if you look at it closely, you will see that at the beginning, the pre and the post HRT are similar in premature ovarian failure as well as the thalassemia patients, but following HRT, the premature ovarian failure group responded better. What does that mean? That this is not the whole story. Now, similarly, if you look at the hip, we do not find a same degree of response, what we have shown before. The same applies to the male patients. So we have learned that hormone replacement therapy corrected the spinal BMD in both genders, indicating that hypogonadism is an important cause. But because it was not completely correctable, compared with premature ovarian failure, we can certainly say that is not the whole story. Now, therefore came the bisphosphonates. Many of you know that probably pamidronate or alendronate or zoledronic acid, these are different generations of bisphosphonate. How do they work? There are two types of bone cell, the bone forming cell or the osteoblast, and the bone decaying cell or the osteoclast. They work by suppressing the osteoclast or the bone decay. Hence the terminology anti-resorption agent. It's very important for you to appreciate that the world literature is full of this information that increased bone resorption takes place in thalassemia patients. Therefore, these were tried and tested. And I won't go into the details, but the caveats of therapy is that bisphosphonates may have side effects. There are risks of osteonecrosis of the jaw in long-term users, and some oral bisphosphonates have been associated with gastrointestinal side effects, including even risk of cancer. Of course, all that data, especially the cancer one, is found in non-thalassemia patients. And it is very important that we now look at the hormone replacement therapy with pamidronate, which is what we did. So we undertook a study to look at the pamidronate and the HRT combination. And these are the markers which we use, the DEXA scan, to look at the quantity. We also use bone quality assessment by taking bone biopsies, and we also use some collagen markers of bone turnover so that we can get a snapshot in a very quick span of time. And again, I won't go into the great details, but the message of the story is that the biochemical bone markers showed decline, indicating good response to treatment, and the bone mineral density improved more in the spine than the hip. Now, this is very important for you to know, and this is what we were discussing earlier. Please understand that bisphosphonate is not magic, and you have to correct the hypogonadism first. Notice here that we have treated the patient with hormone replacement therapy plus bisphosphonate or pamidronate to get the best response. The response was more profound when we looked at the spine rather than the hip. Now, these are the two very important pictures which I will just show you to make a point. Now, there are two types of bone disease, and we are just about publishing this data. Because the data is more than, it has been done with a longitudinal study of over 5 or 6 years, it is very important for you to appreciate that the thalassemia intermediate patients have bone disease, but they do not, or they have hypogonadism, if any, at a very late stage. Now, this particular left-hand panel shows the hematoxylin and eosin stain, and just to show you bone disruption. Now, this patient also shows severe bone disruption. Again, I wouldn't go into any medical jargons. Following pamidronate treatment, please notice that this patient did not respond very well. Why? Because they have what is known as a low bone turnover disease. And this is very important. So if the bone cells are multiplying very rapidly, the coupling unit, the osteoblast and the osteoclast, then it's easier for you to treat. Whereas if they are dormant, it's not easy. This is different from this particular patient with thalassemia major who had disruption, and subsequently the patient responded quite favorably. So in conclusion, what we learned is that bone densitometry is a good idea, the gold standard, but biochemical bone markers may be used in certain cases to understand better. And again, bone biopsies may have a place in certain patients. Now, this is the online MSc course which Richard mentioned, and we are running it for the past 3 years with 40 intakes from all over the world. Before I conclude, I just thought I'll mention a few things about sickle cell disease. Now, The most important point I want to talk about sickle and sickle bone disease is that unlike thalassemics, they are not born with Cooley's triad or problems. However, there are multiple problems. First of all, the endocrine problems are less pronounced. In sickle patients, they do have osteoporosis, and I see many patients with osteopenia, osteoporosis syndrome. The most important thing is there is a myth that because sickle patients are not suffering from osteoporosis, but they have avascular necrosis of the hip or other infarcts, therefore osteoporosis is not important. It is far from true, and we actually presented an abstract in the ASH a few years ago where we found that 57% of our sickle patients have got osteopenia, osteoporosis syndrome. So all patients should also have DEXA scan every yearly, just like our thalassemia patients, one. Number two is that although endocrinopathies are not that common, vitamin D is very, very important to check, and they also have vitamin D parathormone axis disturbance. And some patients do have other abnormalities, including abnormality of the sex steroid metabolism. So I think that the conclusion is that patients should have good exercise and enjoy the lifestyle, which means not smoking and a lot of alcohol, but enjoyment with probably social alcohols and getting together at theater and movies and music and all the interesting things. And then, of course, it is very important for us to make sure that the first line therapy, which is hypogonadism correction, is done. This phosphorate can be a second line, often in combination. And finally, we are working on other drugs, such as strontium, although I have no data in thalassemia or sickle cell patients, because in thalassemia, the osteoblast cells are damaged as well as osteoclast. Now, if you allow these patients to go through normal puberty, then you would expect they'll have normal peak bone mass, and at least you will give them more bone strength. And I will pass you on to Dr. Bajoria, who will tell you that probably we can help them with fertility and pregnancy. Thank you for your listening.